Good morning, everyone. So, after having a very fruitful discussion on day one, now we are just heading for day two program. So, today we'll be discussing mainly kidney cancers, and there are some sponsored session from the pharma which will be discussing prostate cancer and some other issues. So, I would like to invite the chairpersons for this session. Is Sir Anis sir, please. Jagdish sir. So, माइक माइक है तो नहीं नहीं उधर चार्जिंग में लगे हुए थे वो ला रहा है सो
Good morning. Good morning. Can you hear me? Audible? Okay. Now, can I request Dr. Raghunath and Dr. Puneet Ahluwalia, who are the conveners for this session, to start the proceedings? Shall I? Okay. Now, first speaker is Dr. Rakesh Sharma from Hyderabad, and he's going to talk to us on minimizing rhinopathy related issues in robotic NSS. Thank you.
Thank you, sir. Good morning, everyone. Thank you, SOGOCON and Rajiv Gandhi, Amitabh, Sudhir Raval, sir, for this opportunity. So to continue with the de-intensifying slide, change a little bit. De-intensifying treatment in urological cancers. We have the kidney cancers today. So I have been given the role to minimize the side effects or the issues related to the rhinopathy techniques, what we are following in the robotic nerve sparing surgeries. So to introduce, we know that this technique was started way back in 1870, and there have been a lot of developments happened to the technique of doing the partial nephrectomy, the techniques of doing the rhinopathy. A lot of understanding have been happening to do a better partial nephrectomy and give a better outcomes, functional outcomes to the patient. So we all know the main aim of this NSS is a trifecta, which is a negative surgical margin. You're optimizing the retention of a healthy renal tissue and to minimize the surgical complications. So when you do a partial nephrectomy, you keep all these goals in your mind and try to get the best outcome for the patient by following this technique. We follow all the nephrometry scores, the Padua score, and then plan for your surgery to minimize the surgical complication in a given patient. So presently, there are no existing guidelines to advocate which is the best reconstructive technique to minimize the rhinopathy related problems. No agreement exists on the best methodology of performing a rhinopathy technique during a robotic partial nephrectomy. NSS can reduce the renal function, which can vary, but it may be as high as 20% for a treated kidneys. So depending on multifactorial, it will be there. Basically, it will depend on the extent of the healthy tissue, what you have removed, the tumor size, the tumor factors, what we call the patient factor. Then you have the patient having already a pre-existing renal dysfunction, or the duration of ischemia. We say 25 minutes, 60 minutes. There are also a lot of controversies are there. What is the ideal ischemia time? Then the damage caused by the reconstructive procedure during the rhinopathy. So here is what we are mainly going to concentrate. So the rhinopathy techniques have been the conventional interrupted technique, which was with sutures started for the open techniques. It was adapted in the laparoscopy technique also, initially followed even in the robotic technique. Then we had the running knotless sutures, which was the sliding clip technique, which was devised. The barbed sutures came into play over the last 10 years, which made the partial nephrectomies much easier. Even at smaller centers with the barbed suture, you can You can just go and do, you can tighten your sutures without getting worried that there is going to be any cut through of the renal parenchyma. Then came the sutureless technique because there have been continuous work to understand what these previous techniques have created the issues in the preserved renal parenchyma. So there are the hemostatic agents. We have these mechanical, the porcine gelatin, cellulose, collagen, polysaccharides, spheres. Then we have the active agents containing the thrombin, which will interact with the blood or the fluid of the tumor bed, and that will activate it. We had the flowable agents composed of gelatin and mixture of gelatin and thrombin. Again, they will require the fluid or the blood fluid in the tumor bed to activate. We have the fibrin sealants that contain fibrinogen, one of the coagulation factor cascade. So that will activate the coagulation factors there. So there are some trials which have looked into the continuous versus the interrupted suturing techniques. This is a meta-analysis which showed that the interrupted techniques had increased operative time and a longer ischemia time when compared to the continuous technique. So continuous techniques was favored at that time, and no significant differences between the pre and the post-operative GFR was shown. When looking at the barbed versus the non-barbed sutures, the barbed suture had definitely lower operating time because you have to just continuously run through. You have to just pull it. It doesn't loosen after you tighten it. But the non-barbed suture, you have to keep pulling every time, and that itself takes time, especially in a novice surgeon or somebody is learning the technique. Single layer suture technique was associated with shorter operating time and ischemia time than the double layer technique. So these are the few trials which have looked into the rhinography technique, the single layer versus the double layer. And if you see on the percentage of the volume loss in the double layer, we have a higher layer of loss because you do 2 layers of suturing, one in the medullary layer, and then again you do the cortical layer. So you lose a lot of parenchyma, and in all the trials which was confirmed. The post-operative complications, again, which were higher with double layer because you cut through the vessels and you have higher chances of bleeding, you have higher chances of pseudoaneurysm formations. So they have a higher incidence of complications when compared to the single layer technique. Then came the sutureless technique, which was adopted first by Farina et al. In 2021. They had their first publication. This is a different technique where they use high monopolar precision coagulation to stop the bleeding at the tumor bed. They call it as the caramelization of the tumor bed. And whichever areas they feel had to be sutured, they will take a running suture and close mainly the PCS part to prevent any urinary leak in the post-operative period. So that is, it's not completely a sutureless technique, but a minimal suture technique you can call. And there is plus or minus usage of hemostatic agents at the tumor bed to stop the venous and the arterial blood bleeding from that tumor bed. So this is again a meta-analysis of 5 papers which are published during that time. And the numbers were around 634 patients in these 5 papers, and they had compared single sutureless with double layer techniques, mainly a double layer technique with or without usage of the hemostatic agents. So what they found was the operating time obviously was lesser in the sutureless technique when compared to the suturing technique. The warm ischemia time in the forest plot, in all these 3 plots, you can see it favors the sutureless technique, including the decline in GFR. But when it comes to post-operative complication, there has been no major differences between the 2 techniques. It surprises because we feel as a surgeon that if you have not sutured, it is going to bleed. They concluded that sutureless technique is safe and feasible compared to the standard suture technique, adding it reduces the operative time and the warm ischemia time without increasing the post-operative complication. So we have one paper in the laparoscopy, the recent development, which is called as a Variset. It is a readily available usage of hemostatic patch. It doesn't contain any coagulation factors. It contains some cellulose and oxidized cellulose and fibrillinase, which gets activated when it is in contact with the tumor bed fluid. So here was a paper in laparoscopy where they had done 40 patients on each side with the Variset and suture group. The warm ischemia time was statistically significant between the two arms. The operation time and the trifecta outcomes were better with the sutureless technique. Again, the complications were not much of difference. The Varicet arm had some complication compared to the suture arm. The authors concluded the same thing, that it has a reduced overall operation time and the warm ischemia time. Then came the what we call as the GATT patch, which was studied in some pigs. Here also they had similar findings. Then the recent publication has happened in the Journal of Endourology from India, which is from Kishore's group. They had done 43 patients in each arm, and what they found that in the Varicet group they had failed 3 patients where they had to do a cortical renography, but again they had similar findings of reduced warm ischemia time, decreased console time, and early return to renal function when compared to the suture group. So this is a recent meta-analysis in the Chinese Medical Journal, again mentioning the same thing on 10 studies, 1976 patients. They had similar findings that it is combined with the hemostatic agent, the occurrence of urinary leak and the hemostatic complications are much lower, and the warm ischemia time, the operative time are better. So take home, there are no ideal renography techniques, but as we have evolved, we have to see that we have to reduce minimal renography and preserve maximal renal parenchyma. Any form of suture renography will lead to complication. So you have to decide and devise your plan. And sutureless technique with hemostatic agents are the go-to because they have minimal complications and they have the best renal parenchymal functional outcomes. Thank you very much.
So, indeed, you have given us the overall view. So what is your preferred technique?
Sir, before reading this, because I had some discussions with Kishore. Kishore mentioned that I have tried in one patient, sir. But as we all are surgeons and we know suturing is the only thing we have learned from beginning, after putting the Varicet also, I sutured it, sir. But it is something which we will evolve slowly, sir. And if some patients don't give you complication, that will give you the confidence to go in the next one. But you have to sleep well at night. And especially if you are operating in late evening and night, then definitely will not do something like that.
Yeah, exactly. I think people don't have much confidence as of now in Varicet. And
So,
Yeah, I mean, if you remember when we moved on from open partial to laparoscopy, we used to put a patch
Holster.
and we try interrupted suture. That was to prevent the bleeding. We also used to use organ beam laser for the coagulation, but this is not the way to go. I mean, if you are putting a coagulation, a high coagulation, you don't have margins. You don't know what is the margin, negative margin, positive, how much tissue you are charring. So the dispersion of the current is about 5 millimeter to 1 millimeter. You are damaging nephron to the 1 millimeter area. That is, beside that, if you are using a robotic assistance for doing partial nephrectomy, you are not utilizing the full virtue of robotic assistance for doing this surgery. So that's how you should do. I would not recommend, personally, I would not recommend doing a sutureless,
So definitely, sir, we don't coagulate that high intensity coagulation because we know that coagulation will later on lead to some infections also are possible there, and it may bleed in the post-op period. But Varicet is, I think, a very good option, especially in more of exophytic tumors where you need not do.
But Rakesh, I can tell you why you are increasing the cost of the procedure.
Definitely.
You are using a robotic assistance. You can throw out 2 sutures is good enough. And even, I mean, I can discuss with this, but there's always try to dissect the vessel, have under control. You can do a without warm ischemia. We started with the zero ischemia. At one time, zero ischemia was to be big, this thing. Everybody is now trying to clamp it. So the question is, you have a good exposure. You should be able to see nicely. Do a good job. It is a cancer operation. Always remember first cancer, then talk about the minimally invasive part. And I definitely believe in the cost effectiveness. So you can put a Varicet, you can put other thrombin agents, you can put a bioglue, everything you can put, but the cost goes thousands and thousands of dollars, So
Yes. True,
I
sir.
think you are a great surgeon. All of us, we are a great surgeon. Try to utilize your surgical skill. That's what I would say.
Thank you, sir.
So next talk is by Dr. Hemal. He doesn't need introduction to this crowd, and he'll be talking about the partial nephrectomy for complex cases.
First of all, I would like to thank you, Dr. Rawal, President of Society of Genetic Urinary Oncology, Secretary Abhishek Singh, and Scientific Committee of GU Oncology, SOGO team, Professor Kulkarni, he's a past president, Professor Anish Srivastava. And also I'd like to thank the people from United States, especially Dr. Koneti, Dr. Lin, President of Society of Urology Oncology, Dr. Kebel, he was a president of SUO, and coming all the way here to encourage all of us in the field of uro-oncology. And this is a great meeting. And yesterday, what we saw, very quality presentation. So you all are putting a great efforts in making your presentation and giving up to date, the information regarding what's going on, the current status of every possible scenario. I have been given a talk about what's That's how when you are doing, that's why I was talking about the sutureless partial. I mean, like people, they have died. You don't know. I mean, one case I do and oh, this is the best. That's not the way to go. All of us, we should do a good job. That is more important here. Aditya.
Very well. In those patients, positive margin. 1% for the low grades, I understand. Close to a high grade, how many actually?
Yeah, so as I said, we have published our margin positivity rate was 4.5%. No, so again, it depends the margin positivity rate is below 1 millimeter or more than 3 millimeter area. So it's a very different margin positivity rate. It's a focal wide margin positivity rate. But if it is a high grade, as Dr. Srivastava is saying, it's a grade 3, grade 4, wide positive surgical margin. Perhaps, yeah, again, depends on the CT scan image. Even you can do in 6 weeks, and if required, you have to do a radical nephrectomy.
The data tells you that these positive margins, which are high grade, do tend to recur to 3 to 5%. And that would come in early. As you said, you want to follow them up earlier. My question to you is, in these high margin positives, high grade margin positives, do you consider an early revision or you would wait and watch?
No, I'll wait and watch. Absolutely no question of going for. If you on the table, there's a positive surgical margin, as a surgeon talking to the family, you decide to go ahead with the radical nephrectomy, that is fine. But if you have already finished the closure of the kidney, patient is out of the table, I would not do radical nephrectomy right away. At least you are saving the nephron for some time. And even say, for example, there's another study. I mean, so like say time was not enough, so otherwise I can talk. So there's a big tumor there. You can give a neoadjuvant, checkpoint inhibitor, neoadjuvant chemotherapy, then you can reduce and then you go for surgery. So it's various ways of doing things. So these are, but bottom line is, if a high grade cancer, positive surgical margin, follow very closely, and based on that, you take your next decision. Yeah. Yeah, so if you look at the NCCN guidelines, so initially they are saying you can do at 3 to 6 months, then you can increase to the every yearly for 3 years. Now they're extending up to 5 years, and even some of the high risk cases you can go up to 10 years.
After 5 years also, yeah.
Yeah, I mean, if a patient is doing fine, high-grade cancer, but you cannot leave it alone, I have shown these 2 cases. These were referred to me, elsewhere radical nephrectomy done, one guy did it 10 years before. It's not that he did not follow. He followed for 3 years according to guidelines. Now he's a single kidney T1B tumor because he was not having any problem, but he went to emergency because the abdominal flank pain and they found big tumor. So, it's Dan, you were saying something. Oh. Right.
So, like, go to 5 year.
Right.
10,
Right.
These higher.
Right. Yes, Khanna. I agree. So we have multidisciplinary approach, as yesterday all of us we were talking. So always these cases, say margin is positive. We discuss in our tumor board. Okay, this guy has a margin positivity rate. I sent to our medical oncology team. We'll do a CT scan maybe in 3 months or 6 weeks, depending on the patient. Otherwise, we do a CT chest, CT abdomen, pelvis in 3 months. We discuss with the medical oncology and tumor board. They will talk to the patient. Again, the data is not very strong to give them a pembro in these cases, but they do talk to the patient. We can give you an adjuvant pembro for, select group of the cases, but most of the people, they don't agree to go for that. Yes.
Excellent talk, sir, as always. I have 3 questions. Are you using 3D models? That's number 1. We use 3D models, virtual 3D models in India. That's number 1. When do you use neoadjuvant therapy before planning partial nephrectomy? The third one, what is the cost of these absorbable clips? These are not available in India.
Oh, okay. Yeah. So, okay. So the first question, 3D model, we did that. There's no huge advantage. We don't do now routinely. It is more for initially we used to we used to 3D print the kidney. So we had Dr. Atala is at our place. So we have regenerative medicine, and one of our medical students did the work. So we'll create a 3D model, take to the clinic and show the patient, okay, this is the tumor, that's what we are going to do. So that is there. But this augmented reality is very good for the, especially for the newcomers in the game. And that is really going forward, but we don't do routinely. But there are two models, iris model, they can prepare for you. In US, it costs $200. You send the CT imaging, they will create a model for you, they can send it to you. But we do not do routinely. That's number two. Number three, regarding those clips, we have done the study at our center. These are cheaper than the Hemolock clip. So yeah, they are cheaper than the Hemolock clip. And I always really, because this is made up of the polygalactin and polyvital tissues, they get absorbed in 3 months, just like a vital. So why to use a Hemolock clip? Because all of us, we know from our laparoscopic time, open surgery time, clip migrating into the PCS
You
and
can
all
use
that.
it at the base
Yeah.
also. We
Sorry?
can use these clips whenever you encounter a major vessel. You can apply at the base also.
Yeah, exactly.
Maybe
But
avoid-
actually, I wanted to show the other video because of the time. But other case T1B tumor, it was so deep in the vessel, I cut through the artery and I sewed it and I did early unclamping. The now vessel is bleeding. So the clip, I thought to put a clip, but clip will get absorbed. So I took the Gore-Tex suture. So either you put a Gore-Tex suture or tie with the Prolene suture. So for the, if you land into the major vessel, perhaps the closure with the Prolene or Gore-Tex suture is better. But you can, for a small vessel, you can put a lapo clip, perfectly fine.
So when do you use neoadjuvant therapy before platinum?
Yes, so for neoadjuvant therapy, what we do for so all our cases, complex cases, they go to tumor board. So I have at least a series of 30 cases of bilateral tumor, which are T2. So now these T2 tumor, what to do? Suppose actually next week I'm operating one tumor is a 17 centimeter on one side and tumor other side is about 8 centimeter or so. So the question is, we talk to our tumor board, can you give a neoadjuvant chemotherapy? So there are 2-3 papers published on this area. You can give a neoadjuvant therapy that shrinks the tumor because it's an anti-angiogenic factor. But the question is, sometimes the margins becomes more irregular. Our personal series only of 10 cases where we have given neoadjuvant treatment. And what we found, if you give a like post-pembro, we have done 2 cases post-pembro, that causes more scarring around the tumor and it's a more irregular border. But it's a good to do. I mean, I always, if they can give, I'm happy. But the problem for giving a neoadjuvant therapy, they have to do a biopsy. So the patient has to undergo the biopsy. You are doing another procedure for the patient. He's undergoing anesthesia, biopsy, then you are giving a neoadjuvant therapy, then you are doing partial nephrectomy. So, and if you can do a straightforward partial, then why not?
Thank you, sir.
Yeah.
Two questions. How often do you use ICG in your practice?
Sorry?
How often do you use ICG in your practice? And what is the main reason? Whether you use for differential function
Okay. Yeah.
or for
Yeah.
clamping?
Okay, so your question is going to be last because that's what
last
Amtav is
question
saying,
was
yeah, and Amtav is secretary, so we have to listen to him. All right. So we use ICG in every single case, every single case. The reason for ICG are 3 reasons. We are in academic centers. We're working with all our residents, fellows. So the advantage of ICG, you are dissected the vessels, clamp the vessel, give ICG. That's so there is a complete ischemia to the kidney. So you are playing in the safe field and you can do a good job. That is one part. So that is one part. Second part, if you want to do a differential uptake for the tumor, we have published 2 papers for the differentiating between renal cell carcinoma or the cystic. So that's a different ball game, but you give a 0.5 cc ICG because it's based on the uroblastrol. Uroblastrol protein found in the the glomerulus, and that's how the uptake is different with the tumor versus normal parenchyma. Third, by giving a ICG, so the ICG uptake in normal parenchyma is a green light, totally green. And the tumor is a less green. So if you stay in the green, you'll be in negative surgical margin. So you are preventing surgical margin. Now, after doing the tumor part, then you did a rhinorrhaphy. So the question was raised, if you did a rhinorrhaphy, there can be ischemia. You can give ICG, you can check whole kidney is green, there's no ischemia. So these are the advantage of using this. Plus, you can do a super selective clamping. Some of the cases we do a selective clamping, super selective clamping. So in that case, you can do a clamping and then you give ICG, you can see the tumor bearing area is relatively ischemic to the rest of the kidney and you can do a partial nephrectomy in those cases.
One
Thank you, Dr. Kumar. I think no, I think it's enough because yes, thank you.
Oh,
Thank you, sir. Thank you very much. We have now a small discussion on 3 centimeter renal mass in 70 years old, and there are 4 speakers. Stick to the time, and let's have a question at the end. Surveillance, Dr. Abhishek Singh. Dr. Abhishek Singh.
A very good morning, sir. Am I audible, sir?
Sorry, okay.
Hello, am I audible, sir?
Yeah, please go ahead.
Yes,
Please
sir.
go ahead.
A very good morning, respected Raval sir, Kulkarni sir, Ganesh sir, and I acknowledge presence of Hemal sir and Badrinath Konetti sir. Amitabh, thank you for allowing me to present this online, and I'm extremely apologetic that I have not been able to make it in person. I have nothing to disclose apart from the fact that I took help from these two gentlemen in preparing this presentation. So coming to our index situation, it is a 70-year-old gentleman with a 3 centimeter cortical mass, something like what the CT scan is depicting. And is active surveillance a good option is what I am going to put forth. Small renal masses by definition today are contrast enhancing masses which are purely cortical and less than 4 centimeters. The definition has also been evolving for some time, but now this is the consensus that we have. So the information that we have today includes the age, sex, and the size of the tumor. What we do not know is the BMI, CKD category, performance status, and if you look at this particular online calculator by Sara Putzkar et al., what it tells that the chance of this patient dying if he was CKD stage 2 on active surveillance at the end of 5 years is 1% with active surveillance, and obviously there are no complications. If you put the same thing and increase the CKD stage 2 3A, the chance is 0%, and obviously there will be no complications. Again, if you put the timeline to 10 years, the chance that this patient will die on active surveillance due to the malignancy itself is about 1%. So the probability is pretty low. What are the important considerations for these patients, whatever you do? Let us understand the rationale, some data, and clinical practice considerations. What are the patient and family preferences? Illnesses, uncertainty, anxiety, whether the patient can tolerate the surgery, what is his current renal function, what is the life expectancy, and what is tumor biology. If we are able to answer these questions, the option will show itself. We would not have to debate. What is the metastatic potential of this disease? Hands down, from this data from Mayo Clinic, that when the tumor size is less than 3 centimeters, that's the chance that this tumor will metastasize is nearly zero. So what is the significance of 3 centimeters in this case? If you use a cutoff of 4 centimeters, the 70 to 80% of the masses that are malignant will be low grade and low stage. The chance of metastasis, I told, is less than 1% and nearing 0%. Yes, some additional information is once the size grows to more than 3 to 5 centimeters, then these incidence rises, and more than 7 centimeters is about 20%. Patients undergoing active surveillance are unlikely to die of RCCs at the end of 12 years. So this particular study had 958 patients, and the mean duration of active surveillance was 4.73 years. The conversion to active treatment was across the board 15%. For tumor size between 2 to 3 centimeters, it was 16%. So the chance that this patient will get converted into a definitive treatment is also moderate. This tumor was born long before when it presented. So we are seeing the tip of the iceberg. It has taken long time. The biology of this disease may be potentially very slow. The driver mutations are itself decide that the growth of most of these tumors is going to be slow. One important thing is that if you consider active surveillance, more patients are going to die of other causes than active surveillance itself in a long-term follow-up. So that is very important to consider when you plan your treatment. Across the board, the small renal masses grow very slowly. The average rate of growth is about 0.1 centimeter per year, and this could change with the tumor biology. Whenever tumor size increases to more than 3 centimeters, still delayed intervention will happen, but this will not cause metastasis. And even when this consideration is made, 70% remain intervention free at the end of 10 years, which is a large number. So what are the clinical implications of growth rate? If the growth rate is less than 0.5 millimeter per year, the proportion of the patients who will be on active surveillance will be 50 to 80%, and you need to image them at 6 to 12 months. If the growth rate is fast, then the proportion of patients on active surveillance will decrease. If the tumor is less than 2 centimeters, you could consider a shorter interval imaging and a renal mass biopsy. If it is the tumor size is between 2 and 4 centimeters, surely consider a renal biopsy. Image them at around 6 months. Consider an intervention, though we do not have gerantumab PET as yet, but it is likely to be available in the coming years, and which will be a good tool to predict whether it is a clear cell or not, and henceforth make a decision of active surveillance or intervention. Tumor size, growth, and patient preference put together can help you make a decision. Any tumor that is growing more than 0.5 centimeters per year and has a diameter of more than 4 centimeters, in our case, even if we consider 3 centimeters, should be for an intervention. Otherwise, we could easily continue surveillance for this particular patient. Yes, we can consider the emotional and mental quality of life, but this data suggests that as the time progresses, the patient's mental and emotional quality of life improves. So it is not that active surveillance is going to give a poor emotional and mental quality of life to the patient. What about the non-growing small renal masses? If the rate of growth of small renal mass is zero, the risk of metastasis is also zero. So that is very, very important to understand. Non-growing small renal masses, active surveillance is a very, very good option. What about the histology? Clear cell, yes, it is a red flag. These tumors will grow faster and likely to metastasize. So if the rate of growth is high, somebody has biopsied the tumor and it is a clear cell, then you would consider intervention. The growth rate predicts intervention, but it actually does not mark a poor oncological outcome as long as a criteria of 4 centimeters is fulfilled and intervention is done. Remember, these small renal masses can be snails, can be turtles, but can be aggressive and fast growing. So this is the area where we do over diagnosis and over treatment. So one should be wary of that. When the small tumor size is less than 4 centimeters, it is non-progressive or very slowly progressive. This is the window where active surveillance will work the best. So what are the size triggers for enrollment and intervention? Less than 2 centimeters, just forget, and slow growing, let's forget it. 3 to 4 centimeters, less than 1% metastatic risk. Progression to treatment is 30%. Let's keep a trigger of 4 centimeters. If the growth is more, if the growth rate is aggressive, then you can consider a short-term surveillance. If it is more than 4 centimeters, then surely consider an active intervention, because the progression rates are high and metastasis is also significantly higher than the smaller renal mass. So my take-home message is active surveillance for small renal masses suspicious for T1A RCC is safe and durable option. Tumor size is the most reliable indicator for metastatic potential and therefore is the best trigger for intervention. What about the growth rate? Zero growth rate, zero metastatic potential. Elevated growth rate is a marker for intervention. Or if the growth rate is high but not high enough, you can tailor the surveillance. Illness, uncertainty, and patient preference are strong predictors of active surveillance choice and durability. Thank you very much. Thank you for a patient listening.
Thank you, Dr. Abhishek Singh. Now, can we have a next presentation by nephron sparing surgery by Dr. Manas Panda? Thank you. Questions will be at the end, right? Thank you, Dr. Abhishek.
So, very good morning to everyone. I'm myself, Dr. Manas Ranjan Panda, consultant urologist at Chennai Urology and Robotic Institute. At the outset, I would like to thank the organizers, Dr. Amitabh Singh sir and Anand sir, for giving me this opportunity. We have a case scenario of a 70-year-old person with a 3 centimeter renal mass. Small renal masses considered less than 4 centimeter. The management includes the considerations of tumor biology, patient's life expectancy, the baseline renal function, the ability to tolerate surgery, and finally, the patient and family preferences. Life expectancies around the world and in India are on the rise and have reached beyond 70 years as of today. The average growth rate of a small renal mass is 0.28 centimeters per year. With the current diagnostic investigations available, there is a huge diagnostic uncertainty. A recent study on girentuximab shows promising results, but is still used under trial settings. A 2 to 4 centimeter renal mass has 89% chances of malignancy, with aggressive histology seen in 24 to 30% of the patients via radiographic and pathology comparisons, where the aggressive histology shows poorer outcomes. Although the size triggers for enrollment into active surveillance are as given, there is a 1 to 4% chance of metachronous or synchronous metastasis, and 30% of those patients progress to treatment over 3 years. The tumor size, growth, and patient preference definitely influence the delayed intervention, but they do not influence the oncological outcomes. So active surveillance has a higher risk of progression with dependence on repeated investigations based only on size. With the limitation of imaging modalities, the answer to those in whom the disease might be more aggressive is still not answered. So the sword is still hanging over the patient's head. Other ablative therapies, the majority of the studies are single institution retrospective studies. There is a significant heterogeneity in tumor characteristics, surgical approach, ablative modality, and post-procedural monitoring. The protocols after ablation often vary, and there is no consensus established. The role of tumor biopsy and its optimal timing is still a debatable issue. With other demerits of limited availability, need of anesthesia, collateral damage, and repeated ablation sessions needed, focal therapy is still a secondary option. SBRT has been investigated as an option with variable results, with the recent trials showing promising results, but randomized trials are still necessary. So the big question is, what shall we do? A nephron-sparing surgery or partial nephrectomy with various defined methods of enucleation or resection shows promising oncological outcomes which are comparable to radical nephrectomy over a period of time. The partial nephrectomy patients also show better preservation of renal function compared to radical nephrectomy, which improves over time. Following the trifecta of a partial nephrectomy has shown better perioperative outcomes in patients less than 70 years as well as more than 70 years. Although there might be minor increase in post-op complications and intra-op transfusions. A comparative with ablative therapies shows, and a meta-analysis shows better overall survival, cancer-specific survival, and disease-free survival for partial nephrectomy patients. The complications and local recurrence rates and the cost effectiveness is also lower for the ablative therapies. In the AUA 2025 guidelines, it recommends active surveillance for less than 2 centimeter renal masses. They prioritize partial nephrectomy in the management of clinically T1A renal masses. Tumor ablation may be proposed as an alternative approach for renal masses less than 3 centimeter in size, and with a discussion regarding an increased likelihood of tumor persistence or local recurrence after primary tumor ablation. The EAU 2025 guidelines also show evidence of significantly lower cancer-specific mortality for partial nephrectomy patients and a higher disease recurrence and local recurrence after the tumor ablation therapies. There is a weak recommendation for offering active surveillance or tumor ablation and in case of frail and or comorbid patients with small renal masses, although there is a strong recommendation for offering partial nephrectomy to clinically T1A tumors. So nephron-sparing surgery definitely offers a more definite option with complete oncological clearance, With the histopathologic diagnosis in hand, we can prognosticate and risk stratify the patient better, and it has the best functional outcomes. So why subject a patient to all the stress when you can give them a free and cancer-free life? Thank you.
Can we ask Dr. Srinivas to talk on his BRT? Questions will be at the end. Thanks.
Good morning, everyone. I think most of the patient, the tumor treatment related factors have already been discussed since morning for RCCs. So I'd like to directly jump into the topic of my presentation. So essentially for a 70-year-old who's diagnosed with a renal mass, I'll be a little more flexible. I'll just ignore the 3 centimeter mark. But for an operable renal mass with bilateral functional kidneys, obviously varying on the growth potential, there is very little controversy. The gray areas begin when we deal with an inoperable or borderline operable in a frail patient who has more than 4 centimeter mass or even less than 4 centimeter mass with either a cortical or exophytic or a hilar or endophytic lesion, or patients with a solitary kidney with relatively large mass. Only then the discussion or the debate begins. Otherwise, it's either active surveillance or partial nephrectomy. So in this particular patient, I would say I'd propose that SBRT is a potential option, and I feel that it's an emerging concept, and with good data existing, with good long-term data existing. And for most of you already know about SBRT, but for those who are not aware of what is SBRT, it is defined as a method of external beam radiation therapy that accurately delivers a high dose of radiation to an extracranial target in one or few fractions very, very precisely. So through image guidance, etc. So SBRT, essentially we leverage the technology by using the best possible technology at our disposal. We also use in-room volumetric imaging with intra-fraction monitoring. That means even the kidney can move. We are all aware of that. So during the treatment also the intra-fraction monitoring happens and we track the motion of the tumor. And we also leverage biology in the sense, but because whatever we know of radiation therapy for tumors, the radiobiology works differently when we use very high dose per fraction. The mechanism of cell kill is completely different. It could be related to endothelial apoptosis, ceramide sphingomyelinase induced cell death, and some pro-inflammatory signaling for adaptive immunity. Essentially, it accelerates adaptive immunity in the patient. So aim of any modality in such a patient would be to achieve a disease control, to achieve low toxicity, and with very little or no deterioration in renal function. That would be the trifecta for these particular patient. And of course, this needs to be demonstrated in a multi-institutional setting, should be relatively painless or not painful at all, and less expensive and accessible for majority of the patients. And that would be an ideal modality for any, it would be an ideal modality for any patient. So does SBRT satisfy this criteria? That is a question. And the best data comes from a consortium called IROC, International Radiosurgery Oncology Consortium for Kidneys. It's a prospective registry of multiple countries, multiple institutions, and they recently published 5-year outcomes. So we have a long-term outcomes in these patients. The median age was about 70 and above, and this is typically our patient. Medically inoperable in 3/4 of those, that cohort was medically inoperable. Pathological confirmation was noted in nearly 85% of patients. So you can see that pathology, they were not treating tumors which are probably not tumors or cancers. Tumor dimension is clearly about 4 centimeters, so clearly larger tumors than what we usually intervention radiologists or I would say for active surveillance group cohort would consist of. And 30% of them were solitary kidneys. Histology was 85% clear cell carcinomas and few others as well. So it's not a uniform cohort of any RCCs. And BED 10, that the dose which they delivered was 87.5, close to 100 gray was delivered with this particular treatment. And what they noted was, what they demonstrated beautifully was 5-year cancer-specific survival was more than 90%. local failure was just 5%, and regional failure was about 10% in these cohort of patients. Related, things to toxicities were very, very few, hardly any significant toxicities. You can see the eGFR, estimated GFR also came down, but at a very, very steady and slow rate, not very clinically significant for majority of the patients. Now, the question arises if we are dealing with a single kidney. What happens if it is a single kidney? And this was also analyzed as part of this cohort analysis, and the median follow-up of such patients for about 2.5 years. And maximum tumor dimension was close to 4 centimeters, 3.5 centimeters. Tumor more than 4 centimeters was noted in more than a third of patients. And there also, the median eGFR clearance was decrease was about 5 ml per minute, plus minus 10. Different dose fractionation were used, single fraction or 3 fractions were used most commonly. And in this study, they noted that no patient required hemodialysis after SPRT, which is, I think, very, very remarkable. A tumor more than 4 centimeters had a larger reduction in the GFR, which is expected because it could be causing a more bigger damage in that in normal nephrons. Therefore, the deterioration, the dip in the GFR could be slightly higher compared to smaller tumors. Now you can see that the eGFR clearance between smaller and larger tumors, or those who where the GFR decrease versus GFR increase, was also quite similar between patients who had less than 4 centimeters tumor or more than 4 centimeter tumors. They also ran a multivariable logistic model, which they showed that larger tumors essentially had a higher chance, and those who had worse baseline eGFR had worse outcomes compared to whether it was a solitary or bilateral. Similar results were replicated across multiple other centers. This is another meta-analysis which showed very, very similar outcomes, more than 95%, more than 90% cancer-specific survival, local control of close to 95%. So now the question comes, how do we assess response after SPRT, which is a bit tricky. And what the studies have noted is the mean change in growth rate was about 1.3 centimeter per year. That means it reduces by 1.3 centimeters per year after SABR or SPRT. And positive post-treatment biopsies did not correlate with local recurrences, and therefore biopsies are not recommended. So the change you can see is actually very, very gradual. And as you know, SABR is actually sabr. So we need to have a lot of sabr after doing SPRT for RCCs. So if you compare these modalities across patients, of course, SBRT avoids general anesthesia. We could use it for perihilar tumors. We could use for larger tumors, more than 4 centimeters also. It's completely non-invasive. So in that sense, it has multiple other advantages compared to other modalities of treatment. And there has been, this is a very recently published few weeks back, comparative efficacy and safety of ablative therapies compared SBRT, radiofrequency ablation, microwave ablation, and cryoablation. You can see, most importantly, that if you look, and you can see that the tumor size is obviously higher in SBRT series. And very importantly, that if you see at 5 years, if you the tumor size more than 4 centimeters, in radiofrequency ablation, microwave, and cryo, you can see the dip in the local control rates from a 90, close to 95% to 80s compared to SBRT, which maintains that high 90 status. So at least by indirect evidence, of course, there is no head-on comparison, but indirect evidence seems to suggest that for larger tumors, there seems to be an advantage with SBRT, surely. So to conclude, it is a versatile approach, whether it is endophytic or exophytic, whether it is proximal to collecting ducts or not, whether it's anteriorly or posteriorly located lesions, or it's a polar or a mid-polar, interpolar lesion, it could be used, and it is non-invasive. High rates of local controls have been demonstrated in a large prospective study. Low rates of severe toxicities and very little deterioration of eGFR has also been documented. Response assessment is still evolving. As I said, it needs a lot of patients, and then there are new modalities of imaging which can help us in determining responses. It is accessible. A lot of patients can access this treatment very easily, and it has been standardized with standard operating procedures. So I think this is a very accessible and standardized treatment for at least a good percentage of patients. Thank you so much.
Thank you, Dr. Chilikuri. Can we go to the last paper now? Dr. Bharat Gupta talking on ablation. And then we'll have a small discussion. Do we have a time for discussion? 5 minutes?
Yeah, good morning, everyone. So I would like to thank the organizing committee for giving me the opportunity to speak on ablative therapies for small RCCs. So setting the context right, so 3 centimeter mass in a 70-year-old gentleman, so de-escalating without compromising. So these are my disclosures. So those, I would start with the statement that those diseases which medicine cannot cure, knife cures, and those diseases which knife cannot cure, fire cures. So, I'll start with a case, 65-year-old gentleman. He has all the comorbidities you named, diabetes, hypertension, OSA, CAD, ECOG1, showed a incidentally detected mass of 2.9 centimeter in the right kidney. MRI KUB showed a solid enhancing mass. So the patient was referred for ablation to us. So we did a USG guide biopsy from the mass and it showed a clear cell RCC. So this is the mass in the interpolar region of the right kidney. We did a microwave ablation for this lesion post ablation, and this is the 3-month follow-up and a 2-year follow-up. So on 2-year follow-up, there was no recurrence and patient was completely fine. Another case, this is a case of 67-year-old male with a left renal mass post robotic NSS, had a PT1A NX clear cell RCC ISUP grade 2, which patient was on follow-up. On follow-up, after 1 year, patient developed a 1.4 centimeter mass in the upper pole of the left kidney. So we did a USG guide biopsy from the mass. It showed a clear cell RCC. The urologist referred us for a cryoablation. We did it. And after 3 months, we see that there is no enhancement and the tumor is completely gone. So why ablation when the gold standard is surgery? So it is minimally invasive. It preserves renal function, comparable efficacy in T1A renal masses, minimal complications, it is repeatable, and it is backed by guidelines. So if you see the focal therapy guidelines, all the guidelines bar EAU, AUA, ASCO and NCCN, they recommend ablation as the alternative modality to surgery if the patient is not fit for any partial nephrectomy. So there is a strong recommendation of biopsy to be done before any ablative therapies. So this was a comparison which was published by Thompson Group in EAU of Mayo Clinic. So there was around 1,400 patients and it was a retrospective analysis comparing partial nephrectomy and ablation. So around 1,000 patients in the partial nephrectomy group and around 300 patients in the ablation group. There was no difference in recurrent-free survival in partial nephrectomy and ablation groups. So if you see the Kaplan-Meier curves, there is some gap in the overall survival when compared to partial nephrectomy and ablation. The reason being the patients in the ablation group were of the older age group and having multiple comorbidities. If you see the cancer-specific survival and metastasis-free survival was similar in both the groups. So this was a very good meta-analysis which compared cryoablation with the robotic partial nephrectomy for T1A renal masses. So total 10 studies were included in this meta-analysis and there was no difference in recurrence-free survival in both the groups. So I would say in this study, the renal function was similar in both the groups. Complications were significantly less in the cryo and recurrence rates were slightly more in cryoablation rather than partial nephrectomy. So this is another SEER cancer registry of around 4,500 patients in which 18% patients, around 800 underwent ablation and around 3,700 patients underwent partial nephrectomy. So the cancer specific survival was almost similar in both the groups And you see similar graphs of overall survival and cancer-specific survival and metastasis-free survival. So this was a prospective, now comparing to SBRT, this was a prospective randomized trial of SBRT comparing with the radiofrequency ablation of small renal masses. This was a Radstral meta-analysis, RCT comparing both. So in this group, interesting finding was when you biopsy the patients having undergone SBRT, so 33% of the patients had positive biopsy for tumor. So, what are the? Yeah. So, pathological CR was 33%, it was 100% in RFA. So, hallmarks of a successful ablative treatment is it is effective, it has reduced risks, faster recovery, and it is actually patient centered. So, ablative therapies have stood the test of time for all these parameters. The only problem is there are no RCTs comparing partial nephrectomy and ablative therapies. So few RCTs which were actually started like conserve trials, SURAB trial and ROSE trial, which could not recruit sufficient number of patients. Reason being there is no equipoise between both the groups. It is very difficult to randomize patients into partial nephrectomy and ablation. So this was a protocol, a cohort embedded RCT, which was actually, it has designed the way how an RCT should be conducted between partial ablation and between partial nephrectomy and ablative therapies. So coming to all the three options, nephron sparing surgery still remains the gold standard as level 1 evidence is still lacking for ablative therapies. Active surveillance will always be a point of discussion. SBRT is still not there in the guidelines for focal renal masses. And ablative, I would say for T1A and select B1, T1B tumors, ablation is almost similar to nephron sparing surgery. The important things we should consider before giving patients a treatment option is the patient and family preferences, ability to tolerate surgery, renal function, patient life expectancy, and tumor biology. So to conclude, level 1 evidence is still lacking. We need to define oncological outcomes, what we want to achieve for a 3 centimeter RCC, and urologists are actually the gatekeepers, and this balanced approach, patient-centric approach should be followed before giving a decision of any therapy. Thank you.
Thank you, Dr. Gupta. We come to the end of this talks now. Can we have some questions now? Yeah.
Yeah, that is actually.
That you will not attempt for ablative therapy like any like non-otherwise specified or
With
unspecified.
renal mass biopsy is for sometimes for oncocytic neoplasm they are not able to differentiate between oncocytoma and chromophobe RCC, and even for angiomyolipomas. So if it is diagnosed on a biopsy, we would avoid ablative therapy.
No, I think
so 15% of the patients, if you biopsy small renal masses, so they will be benign.
no. My question is, if suppose on the biopsy some grade 4 comes, or like some not otherwise specified or translocation associated come, do you still want to do ablative therapy on those
Only
patients?
3 centimeter mass, it is very rare, it will come grade 4. So these are generally of a good biology and histology, slow growing masses.
Okay. And my other question is to Dr. Srinivas, sir. If so, when we follow these masses after the ablative therapies, so the definition of recurrence is suppose the mass is increasing in size or it is showing some enhancement or contrast in a CT scan. So how do we follow up these patients after radiotherapy? What is the criteria that there is recurrence?
Contrast enhancement has shown not to be not correlate with the response. So therefore, we do not rely on contrast enhancement alone. So there are multiple other imaging parameters which need to be looked at. As I said, 95% is a local control rate. So if there is some kind of a bloating, never believe that it's local progression already. So unless there is a consistent increase in the size of the tumor, you cannot really say that it is local progression. So therefore, In fact, the IROC consortium clearly mentions that biopsy is discouraged. The ones which pathological confirmation, which has some of the studies have shown that it is not correlating with the local control rates. So even though at say 1 year, the biopsy may show residual tumor, it may not actually lead to local failure or local progression. Therefore, local biopsy, doing biopsies is of waste. Unless there is a consistent increase in the size of the tumor. As I said, that is something which is evolving. We are learning that how to assess response quickly because patients are anxious. We need to tell them that everything is good. But that is the only kind of evolving thing with SBRT. But otherwise, as I said, local control rates are very good on long-term follow-up.
Main challenge is to assess response after SBRT. So in this, if you see the Ratzer study, ablation, sir, after 1 month, we are quite sure that the tumor is actually gone. So there will be no enhancement, there will be complete necrosis, and with time, there will be shrinking of the ablative zones.
Thank you. Thank you. I think we have to speed up the things. Next.
So may I call Dr. Mahendra for the next talk? And no, Dr. Gagan, sorry. Gagan Saini for the next.
Morning. It's very encouraging to see all acclaimed seniors early in the morning here to learn. It's very encouraging. I'm Gagan Saini, and my mandate is to talk beyond what Srinivas was talking, beyond small renal masses, expanding indications of SBRT. So let's take it in context. It's not a very common malignancy, RCC. It's 14th most common malignancy, but the incidence seems to be rising, mainly driven by imaging, because imaging is getting more and more common. For other diseases, patients get imaged and they get diagnosed. The mortality is decreasing, so to say, maybe because of early diagnosis only. The 5-year survival still remains very high and very encouraging. So this is about what the previous discussion was coming and going from. RCC has always been radio resistant. Everyone, all of you, urologists, radiation oncologists, everyone has read only one word related to RCC, and that's radio resistance. So let's understand the change from radio resistance, and today we are talking of ablative treatment, and where is all this coming from? So this is a old paper, and this is about radiobiology, and these papers are always old because radiobiology was studied some time back. And this is the the D bar for RCC, that's 4.80. D bar is the mean dose required to have any biological effect in a tumor. So that's 4.80 gray. That's not 2 gray per fraction, 1.8, even 3 gray, 1310, the way it's given. It's 4.8. It's a very huge amount of dose. And that is why it was probably not done before, because what happens in radiotherapy, now we radiation oncologists are very happy with these graphs, and I hope you are too. This graph begins from here, and here is the dose. So if you see the screen, I have the pointers there. This graph begins from here, and here is the dose. And as the dose progresses, when we are doing fractionated radiation, we hope the tumor will eventually, resolve, depending on the radiosensitivity. Why we do fractionated is because the late reacting tissues, the normal tissue, it lags behind in terms of its response, and that is a good thing, right? We don't want normal tissues to get toxicity. But when we give high dose per fraction, the benefit really comes very fast with the high dose per fraction. But unfortunately, the normal tissue gets even more damage with the high dose per fraction. This graph shows you that. It's from here, suddenly nose diving up to here. Now, what I'm trying to tell you is that unless we have a treatment which is very, very confined, very, very tied down around the target, we really can't get radiosensitivity. And then there are other biological effects of radiation. So radiation is not a burning modality. Radiation is a biological modality which sends downstream signaling, and downstream signaling causes this endothelial apoptosis and so many other immune related mechanisms. And this is the basis of radioresistance. So when we are able to give the dose in such a way to the tumor, which is very, very focused, and really not much dose is going to the surrounding structures, you can see the rest of the kidney is really getting spared, then say after 1.5 to 2 years, you will see a response. Challenging, everything is a challenge in medicine. Challenging to see the response rate, sure. Impossible, no. AJCC staging for RCC, early T1As. It's been discussed by Srinivas. 3-4 speakers spoke about it. Long story short, a very good local control can be expected. We have a lot of retrospective studies, 95, at least 90% in most studies. So let's come to beyond renal masses, small renal masses. So this is a paper on SBRT for primary renal cancer. They basically gave 36 in 3 or 40 in 5. And they showed that most patients, they had a response or they had a stabilization. Only a couple of patients had progression, and that too after more than 2 years. So they reported results that by RECIST at 1 year, very good results, 100%. Median pre-treatment growth rate, yes, this is one way of assessing SBRT response. Median pre-treatment growth rate was 0.8 centimeter per year, whereas after SBRT, it came down to 0. So what SBRT does is makes the cell quiescent. And how does it do that? It makes the cell quiescent by damaging the DNA, which is basically making the cell divide, which is basically fueling the further growth, further proliferation of the cancer cell. And therefore, SBRT is a biological treatment. SBRT is not a physical treatment like ablation might be, and even surgery. So for this report, about 94% disease control was reported and hardly any toxicities. But yes, there was a decline in GFR because the nephrons, they are surrounding the tumor, they do get damaged. And this is a very encouraging adverse effect profile. This is the TROG Fast Track 2 trial, published very recently. And again, they received a very good amount of radiation. And long story short, very good local control above of 95%. Freedom from distant failure also quite good. And the cancer-specific survival was very, very encouraging. The IROC consortium that was being talked about, I'm just quoting it in context of SBRT in solitary kidneys. So part of that consortium report was talking about SBRT in solitary kidneys. Now, this is definitely a challenging situation. 81 patients with solitary kidney underwent SBRT and mean age was 67, what you would expect. 97.5% had good performance status and median tumor diameter was 3.7 centimeters. However, 1/3 of tumors were more than 4 centimeters in size. The results were quite good. The GFR did decrease. You should always expect a 10% decrease in GFR after radiation therapy, at least a 10% decrease in GFR. No patient with solitary kidney required dialysis. 2 years control rate was 98% local, progression-free survival 77.5, cancer-specific survival 98%, and overall survival 81.5, reasonably similar to surgery. Of course, the follow-up is not long-term. There was no significant difference in the renal function or oncological outcomes between the cohorts. So if you remember, IROC was reporting on all the results, all the pooled analysis of all SBRTs for, So therefore, what the last line says is that there was no difference in oncological outcomes with respect to the normal patients with 2 kidneys and with solitary kidney. So it was quite effective. So other options are, of course, active surveillance and interventional ablation. I'll just take one slide of SBRT versus surgery versus ablation. This is nephrectomy, this is ablation, this is SBRT, local control, tumor size, invasiveness, and impact. This is the gold standard, but with respect to ablation and SBRT, I would definitely say that it's a less invasive treatment and can take care of larger tumors. You don't have a size limitation and the results are similar or better, I would say. SBRT for oligometastatic RCC. Well, oligometastasis, we discuss it a lot in our oncology discussions. It's basically a clinical state. We count the number of metastases. We say 1 is oligometastasis. Someone says less than 3, someone says less than 5. But actually, SBRT is a clinical state. Now, what do I mean by that? Is that between localized and metastatic disease, it's an intermediate stage. Now, how do you define that intermediate stage? Again, we radiation oncologists love graphs. I'll take you to a graph, but I'm sure you will love it. Here is the number of days. You will, sir. Here is the number of days, and here is this log of cells, number of cells, and just see this black line. You start from here, and over the time, this cancer cell grows, and say this dotted line, this broken line is any endpoint of that cancer, death, or whatever it may be. This is a graph. So when this metastasis happens, it will follow this natural, exponential growth. But if you do SBRT or you do any oligometastatic treatment, you push this curve down and this one becomes the next line. Don't tell me that my time is already over. So this one, it moves to this side, and this is the biological benefit that we gain. Now, this biological benefit actually depends upon the biology of the treatment, biology of the patient, biology of the tumor. So this is some papers which are using SBRT to defer systemic therapy in oligometastatic RCC. And yes, the therapy did get deferred, and it was especially better in a single metastasis, especially better in bone metastasis. The average was about 12 months, 12 months benefit. These are some ongoing trials. Most of these questions are not answered. These are just expanding indications. These have not been expanded to really, but yes, these are very encouraging and are in sound logic with other oncological principles which we follow in other diseases. So these are some phase 3 trials. What about oligoprogression? This is again a phase 2 paper. Again, the benefit of oligoprogression patients on TKI was seen in patients who were doing well on TKI. They had an even better benefit when SBRTs were added. This is a very interesting paper, again a phase 2 trial. And here they gave SBRT to every progression unless it was not possible to give SBRT to a progression, which of course is also possible because not every progression will be localized and will be within the realm of radiation field. So they gave, and eventually they reported the results. And the result is that SBRT can extend the duration of ongoing systemic therapy. So the patient is on an ongoing systemic therapy. You give SBRT to the progression. You don't need to change the systemic therapy in most patients for more than 6 months in 70%. And the median benefit was 11.1 months. Again, that 1 year benefit is there in oligoprogression, oligometastasis and stuff like that. But yet ongoing trials. And of course, we need to incorporate ICIs or IOs, the immune checkpoint inhibitors or immuno-oncology, which have a potential to, disrupt the mathematics wherever they can. So long story short, in a disease state which is oligometastatic, SBRT can improve local control, prolong overall survival in PFS. In an oligorecurrent disease, improves local control, delays the start of systemic therapy. In an oligoprogressive disease, it can again delay the change of systemic therapy, can prolong overall survival and local control. In a polymetastatic disease to begin with, you may still improve local control and induce immune response, which will be benefit for immune checkpoint inhibitors. It is there in guidelines and consensus. What I checked was that in EAU in 2022, SBRT has been mentioned under minimally invasive options and in NCCN as well. The ISRS practice guidelines, of course, they are radiosurgery guidelines. So one would say that that has to be there. So discounting that, it is still there in international guidelines. What else is new? Cytoreductive SBRT. All urologists know about cytoreductive surgery, and it has been there since the cytokine era. SBRT primary can reduce tumor burden, but trials are going on. We don't have the results. There is something called as adaptive RT. That is a new thing. And with MRI guidance, it can be very good because you see the MRI during the radiation. It's an MRI guided radiotherapy on MR-Linac, and you can avoid the hilum whenever you can, and that really makes a lot of difference. Other future directions, randomized trials are coming, proton trials are coming, spare surgery, integration with ICIs, and as I mentioned, we need biomarkers for patient selection. Currently, there are no biomarkers. You just do what you feel like. You see the size, you throw your treatment. But maybe there are more biomarkers which can help us select. Finishing, take-home messages, SBRT safely up to 10 centimeters, even in solitary kidneys and central masses with good image guidance and adaptive treatment, excellent local control, low grade 3 toxicity, promising role in oligomets, oligoprogression, and oligorecurrence. So, and adaptive RT, please remember, is the new kid on the block. And this is where radiation therapy will go to, especially for such critical cases like RCC. Thank you for your attention. I don't know if I've exceeded my time, but if I have, I'm really sorry for that.
Thank you, Dr. Saini. We can go to the next presentation now. Kyle leak management by via intervention radiology, Dr. KM Mahendra. Request to keep the time.
Okay, sir. Thank. Good morning. First of all, I would thank all organizers for giving me an opportunity to present over here. And Today's my topic is leak management via interventional radiology. First of all, we'll go to a little bit about anatomy and physiology. So the Konstantin Kopp is the first person who described intervention. Who described the role of interventional radiology in various pathologies of lymphatic channels. So lymphatic system that's in the body is of two types. That's the peripheral system and central systems. Peripheral system predominantly involves the lower limb that's studied by the pedal lymphangiography, and central system that's involves the lumbar trunks, cisterna chyli, and the thoracic duct. That's the studied by intranodal lymphangiography, or it's a mesenteric nodal lymphangiography, or it can be a transhepatic lymphangiography. The cisterna chyli, that's collection circular dilatation of lymphatic channels at the level of D12, L1, L2 in the retrocranial space, which is formed by two lumbar and intestinal lymphatic trunks. These are some variations of thoracic duct. That's it can be on right side, can be on left side, can show duplications and plexiform variants. It can be absent at places. This is the anatomy. We can see here the lumbar trunks forming the thoracic duct, and we can see here cisterna chyli, which commonly inverted V or Y shaped, and we can see here the cephalid course. Terminally, it terminates into the jugular venous angle, or it can terminate at the internal jugular vein or external jugular vein or subclavian veins. Now, coming to the indications of lymphangiography, when we do a lymphangiography here, we do in a chyleaks, most commonly a post-op chyleaks, presenting as chylosociety, chylothorax, a chyluria, or post-op lymphoceles. And before doing the lymphangiography, we should be very careful of when it is contraindicated. We have to do very careful in pulmonary insufficiency patients or cardiac shunt patients. Commonly, it's a most common indication is an iatrogenic cause, that's post retroperitoneal lymphadenectomies, pancreatic duodenectomies, or esophagectomies. So we classify the chyleaks as low output and high output. Suppose if it is less than 1000 ml, then that's commonly we can manage by medical management. High output more than 1000 ml, that needs an intervention management or surgical ligations. See here, suppose in a low output chyleaks, conservative management is preferred. That's low fat diet, medium chain triglyceride diets, somatostatin analogs, octreotide injection that acts by reducing the splanchnic flow and lymph production and total parenteral nutrition, and minimal invasive procedural paracentesis weekly or intermittent continuous drainage via the intervening catheters. Suppose if not reduced within 3 weeks, then we go for a lymphangiography or without embolization. And if not reduced even with the lymphangiography, then that's we go for the surgical exploration if it's surgically fit, or peritoneal venous shunting if unfit for surgery. So techniques of lymphangiography, basically the most common technique is an intranodal lymphangiography that's done through the inguinal lymph node approach. That is, we use basically lipidol, the oil contrast agent, that can be of therapeutic and diagnostic effect. So we puncture a inguinal lymph node here and slowly inject the lipidol wherever. We can see here the beta opacification of the lymph node with lymphatic pelvic lymphatics, and in the delayed images we can see here cisterna chyli and thoracic duct opacification. And what's the next step? The next step is to cannulate the lymphatic thoracic duct cisterna chyli via transabdominal approach under fluoro guidance. And we're using the Chiba needle, that's 20 centimeters Chiba needle, followed by the cannulation, guide wire insertion, and microcatheter insertion. Via microcatheter, we embolize the duct using glue or coils. We can see here we have taken the puncture here via Chiba needle and puncture the cisterna chyli. And sometimes when this attempt, suppose if we don't see a chyleak in the intranodal lymphangiography, then we have the other option, that's a cannulation of thoracic duct at the point where it terminates into the jugular venous angle. That's called the retrograde venous approach. And this is applied when there are extensive disruption of pelvic lymphatics. And you can see here, this is retrograde cannulation and opacification of thoracic duct here. And we have seen the active leak here. So that embolized by the glue. And this is the glue. You can see here the active leak and embolized with the glue. Embolization material, usually we use a glue 1:2 to 1:4 ratios. And here the patient, here the post-nephrectomy, present with the chylous ascites. You can see here the active leak through the internal lymphangiography, attempted the transabdominal approach that failed, and even the retrograde venous approach also failed. So that in this case, they punctured the lymphocyte percutaneously and injected the glue. That's with a complete resolution of chylous ascites. Here also the patient of post-nephrectomy on the right side, the failure of the intranodal lymphangiography and retrograde venous approach. Here we used transhepatic lymphangiography. Transhepatic lymphangiography, we can see the active leak here and followed by the glue injection. So, and these are the pelvic lymphocytes. The pelvic lymphocytes usually managed by the injection or at the inguinal lymph node and followed by the glue injection. We can see here the active leak into the lymphocyte cavity and there's a glue cast here in the lymphocyte. That's completely a resolution of these lymphocytes. Now the count our own experiences. Here, the patient with a CA prostate and RCC post-op, the presented with the chylous ascites. We can see here, we have done the internal lymphangiography bilaterally, and we didn't see any active leak. So then we did a CT guided embolization of the lymphatic duct, followed by the resolution of chylous ascites. And the next case is the CA trunk with a metastatic RCC post-op, and the patient after 14th day presented with a neck swelling, and followed by the ascites. Outside ultrasound showed the ascites. That turned out to be chylous ascites. So we decided to go for the lymphangiography with embolization. Bilateral inguinal lymphangiography done. That means the puncture of the inguinal nodes with the opacification. We can see the clear-cut opacification of pelvic lymphatics. However, we couldn't see any active leak. In these kind of cases, we did a CT-guided embolization of lymphatics at the level of renal hilum, so complete resolution of the ascites. And the next case is the CA endometrium case, post-pelvic para-aortic lymphadenectomy presented with ascites. Paracentesis showed chylous ascites. Here, we have done this inguinal node puncture with a nodal lymphangiography, and we can see the active leak here, and the active leak of lipidol you can see here, and is followed by the glue embolization. That's a complete resolution. The recent advances would be like a thoracic duct stent placement. We can place in a retrograde venous approach or in the transcervical approach. We can place a stent, and it's got a very good results nowadays. You can see we have placed a thoracic duct stent. And the recently developing is this one's diagnostic transhepatic lymphangiograms. So whenever there is no leak from the intranodal approach or retrograde venous approach, or all the approaches fails, there sometimes we have to think over the one of the last approach. There's a transhepatic approach that gives the answer in whenever we don't get the chyle leak, and we can embolize through this approach. And so chyle leak can occur anywhere in the body, and that's mainly due to iatrogenic causes. And the lymphangiography and lymphatic interventions, embolization, they are safe and effective in the management of these patients. And this is my research article, our research article on lymphangiography, lymphatic interventions. Thank you. Thanks a lot for.
Dr. Raghavan on here. Dr. Raghavan.
Hi, everyone. Can you see my screen?
Yes, sir.
Yeah, okay. Go ahead.
Yes, sir. We
Can,
can see your screen, sir. You can go ahead.
Okay, just give me a second. All right, I got it. Okay, thank you, everyone. Thank you, Dr. Amitabh and Dr. Vinit Talwar for this kind invitation for me to share with you on my experiences with kidney cancer. I'm a medical oncologist and I'm based out of the National Cancer Center, Singapore. I currently chair the Division of Medical Oncology there. So it's great to be able to talk to you today. Let me just quickly go through a slide. I have about 15 minutes, so I'll try to compress as much as I can into this topic of non-clear cell RCC. I think clear cell RCC is something everyone is very familiar with. We see large numbers of these patients. However, non-clear cell is not something as common. So let me see if I can control these slides. Sorry, are my slides moving?
So I can see your front slides, sir, main slide, but they are not moving.
Okay, let me reshare again. I apologize. I don't know why it's not moving. Okay, can you see my slide set now? And
Yeah.
is it moving?
Yeah,
It's moving,
yeah,
yeah?
it's moving right now.
Okay, these are my disclosures. So for the outline of my talk today, I have a few items that I'll be discussing. One is, firstly, non-clear cell is really a tale of many tumors. It shouldn't be lumped as one category, which we have been doing for many years, and I'll show you why this is the case. And that could be also the reason why we get variable responses depending on the particular subtype of non-clear cell histology. We also briefly go through new pathological and molecular subtyping, clinical trials to support the use of some of these therapies for particular subtypes of non-clear cell, and I will summarize after going through some guidelines. So non-clear cell basically account for about 25% of all kidney cancers. And here in the pie chart, you can see broadly these are numbers you're familiar with. Papillary renal cell carcinoma accounts for the majority of non-clear cell carcinoma, more than 50% of them, and 15% overall. Chromophobe is about 5%, and the balance 5% account for numerous other subtypes. Some of the more common ones you might be familiar with includes collecting duct, the translocation subtype, and also some that are unclassified. Amongst those clear cell patients and even some non-clear cell patients, there are patients who have dedifferentiated sarcomatoid features as well. And this accounts for about 10% of all kidney cancers. So in the past, this was the broad division. So patients clear cell, the driver behind it was the Von-Hippel-Lindau gene, which was discovered. And now, of course, we have therapies targeting that as well. And for the non-clear cell, papillary was divided into type 1 and type 2. Papillary type 1, the minority of papillary RCCs driven by MET, which was the driver, and fumarate hydroxylase deficiency drove the papillary type 2. Of course, now we have many other, subtypes, which I'll talk to you in a short while. Chromophobes and oncocytoma are the other more common non-clear cell RCC subtypes. So this is a very evolving space. First, you see in 2016, we had, numerous subtypes of renal cell tumors, but now there are broad classifications. So in 2022, there was quite a lot of work done on this, published in the Urinary and Male Genital Tumors Pathological Classifiers. And here you can see outside of clear cell carcinomas, you have papillary, oncocytic, and chromophobe renal tumors, collecting duct, which is more akin to urothelial carcinomas in terms of how we treat them, and the other subtypes. And now you have this molecularly defined renal carcinomas. And these are tumors where we understand better about their disease biology and cause, and as such have identified targets that we can now use some of the therapies that we have developed over the years to treat these patients in a more targeted manner, heralding the beginning of personalized medicine in this space. So again, as mentioned to you, some nomenclature changes. So firstly, that we don't have papillary RCC type 1 and type 2 anymore. And for some of the others, right, renal medullary carcinoma, we have actually identified the gene that drives it. Similarly, the hereditary leiomyomatosis RCC is now called FH deficient RCC. So there's some of these changes. So you may see some of this new terminology when your pathologists report non-clear cell RCC. Okay, so this path or journey towards characterizing these tumors started quite some time back. So this is from a New England Journal paper from 2016. So the Tumor Genome Atlas actually had done a lot of work classifying numerous tumors, and of course, non-clear cell RCC being one of them. So papillary RCC, when the TCGA sequenced these tumors, specifically looking at 161 in this report, they found type 1 was driven by MET pathway alterations, while type 2 driven by numerous other alterations, not just specifically related to one type of mutation. So you see CDKN2A, SETD2, TFE3 fusions. These are some of the mutations driving papillary RCC type 2. Now, for sarcomatoid RCC, you can see here, it is also something that's genomically driven as well. You can see CDK2A accounting for about 30% of the mutations seen in this cohort of 26 patients. And this finding actually puts it as potentially susceptible to palbociclib. So some of you who may treat breast cancer may be familiar with this therapy. And NF2GAs found in about 1/5 of the patients were associated with everolimus sensitivity. So prior to this, sarcomatoid is an aggressive phenotype, and what we all know is that they respond quite poorly to standard treatment like oral TKIs, and now we know much more, and later on I'll show you data with immunotherapy for this subtype. Now, collecting duct, as I mentioned, more akin to urothelial carcinomas, we use chemotherapy. However, amongst 17 patients who were sequenced, there was about half of them who had some targetable mutations like NF2GAs and SMARC CB1GA genomic alteration. So this is an example of a patient, 75-year-old man, and typically we would give a platinum-based chemotherapy, which we did. Unfortunately, patients still, which I think this was a case study published by Dr. Sumanta Pal. And in that study, he then profiled the patient, found to have CDKN2A, and found a great clinical response. You can see here the lung metastasis had shrunk significantly after being given palbociclib. So again, highlighting the fact that all these tumors should not be lumped together and put into one trial. Unfortunately, this was the case in the early days. There are many reasons for it. I think one, because these tumors are relatively uncommon, it's very hard to recruit a single group, for example, chromophobes alone or sarcomatoids alone. Papillary, on the other hand, a sizable number, but still challenging, and I'll show you later some data, some phase 3 trials that unfortunately could not be recruited, could not complete because of poor recruitment. So the earlier trials, as I mentioned, they lumped them all together. So in this trial, as ESPN trial published in 2016, papillary chromophobe unclassified translocation all put together, and they were randomized to sunitinib, everolimus, and then crossed over. Now, this trial projected to hit 108 patients, not a very large number considering it's a multi-center trial. Unfortunately, it could not hit the target. So at the end, the trial closed at about 68 patients. As you can see here, the numbers were relatively small. Median OS varied substantially. So chromophobes, some of them did very, very well with sunitinib up to 30 months. And there were other subtypes that did poorly, like sarcomatoid with clear cell features, with only 7 months median OS with sunitinib. In general, patients on sunitinib seem to have fared better. However, there were certain subtypes where the everolimus probably could have worked better as well, and we'll talk about those in a short while. Now, Aspen didn't have a crossover, so it's a direct sunitinib versus everolimus comparison. Again, they lumped all these tumors together, and as you can see here, there was a benefit of sunitinib over everolimus. But if you look at the figure below that, you can clearly see in terms of subgroups, those who had chromophobe seem to do better with everolimus versus papillary that seem to do better with sunitinib, right? So these were some of the subgroup analysis that came out of those studies. So now, broadly, all these trials had combined non-clear cell Some of them were actually part of bigger phase 3 trials that had clear cell as well. So this particular trial, Record 3, the third one listed there, had about 66 patients, but the bulk of the patients were all clear cell. So they did a subgroup analysis. The rest were smaller trials that could not hit accrual, like ESPN. Aspen did better with 108 patients. Again, sunitinib showing superiority over everolimus, except for certain subgroups like chromophobe. So instead of lumping all together, which really didn't help us very much, now I think the field has gone down the path of looking at rationally selected drugs, right? So again, this was aided by the fact that many of these studies on sequencing these tumors and characterizing their molecular drivers have actually changed the way we approach these tumor types. So targeted therapy, again, widely used in clear cell. However, in non-clear cell, not so great responses. So you are typically used to seeing responses of about 40 to 45% with TKIs. And in this non-clear cell space, you're looking at very dismal 15% in a number of these studies, erlotinib, sunitinib in SUPAP, and the best of which was a combination study with bev erlotinib. Again, very small numbers and response rates of 35%, but relatively modest PFS. So there came the drug savolitinib. Okay, so savolitinib is a MET inhibitor, and as we know, a significant number of patients previously classified as papillary type 1, their tumors are driven by the MET gene, oncogene. So here you can see that patients who were given savolitinib actually had much better responses, as shown by the waterfall plots and also the Kaplan-Meier curves here. So as such, it seemed rational to take this drug forward, and that came about with another trial by Montipal called SWOG 1500. It was a randomized phase 2 trial, 4-arm study, pretty ambitious study with patients being randomized to sunitinib, cabozantinib, crizotinib, and savolitinib. Now, we have seen a bit of data in metastatic papillary RCC patients with sunitinib, with savolitinib, and there was also data with cabozantinib and crizotinib, which I didn't have time to show, hence the choice of these 4 therapies. Now, what came out was cabozantinib came out the winner in terms of progression-free survival benefit. You can see here 9 months versus 5.6. So sunitinib was the previous standard of care. And now for papillary RCC, it's now been supplanted by cabozantinib at 9 months with objective response rates of nearly 5 times better. So this was quite a big improvement. Now, the next step was looking at molecular drivers. So, papillary type 1s in the past called papillary type 1s are driven by MET alterations. And as you can see here, in this study, patients were randomized, but it was a molecularly driven trial because it was the first trial to use MET alteration as a selection criteria. So patients were randomized to savolitinib versus sunitinib. Unfortunately, this, like many prior trials in the space, had to close early because they didn't hit the recruitment target. So the trial did show some benefit favoring savolitinib, but it was not statistically significant. As you can see here, the 95% confidence interval extends beyond 1. Overall response rate, however, did show savolitinib doing better. And prior to that, at about the same time, there was also studies, earlier phase studies looking at combining savolitinib with durvalumab, and that actually showed more than 50% objective responses. So when you add immunotherapy to savolitinib, these tumors actually shrink much better. So that was the rationale for this trial, SAMETA. So this time, again, hoping that we will not hit that wall where there's insufficient patients recruited. So it was planned for 200 patients, 2 to 1 to 1 randomization, 2 patients for savolitinib, durvalumab versus 1 each sunitinib, durvalumab, up to a point when they reach 200. We are part of that trial, and unfortunately, I think now we are at just about 150 patients, so we're still not completely accrued. So hopefully this will give us a new standard of care, perhaps with a TKI versus, and immunotherapy combination. The other trial is using zanzalintinib. So zanzalintinib is actually similar to cabozantinib, except it has a shorter half-life. So it's a very similar kind of multi-kinase VEGF TKI plus nivolumab versus sunitinib. And this trial, we have completed accrual. So I am actively involved in this trial as a steering committee member, and we completed accrual about 2 months ago, and hopefully we'll get some data in the next half a year or more. So broadly, immunotherapy, as you can see here, very effective even in non-clear cell, specifically papillaries respond relatively well,
Dr.
20 over
Rangan, time
percent.
up.
Okay, sorry. I'll just quickly run through this. Yeah. So again, want to highlight chromophobes don't do so well with immunotherapy, so you may not want to use that combination. Now, just running through some of the other combinations, whether it's carbo, atezo, carbo, nivo, the overall objective response rates are very good, 40 over percent. Bev, atezo, not so great. Lenva, pembro, very good, 53%. And I'll just highlight this trial, B61. This is the PEMLAN trial in non-clear cell. You can see here, depending on which subtype, they're all pretty impressive. Even chromophobes, not so responsive to immunotherapy, had about 34.5% responses. So pretty impressive, right? Chromophobe, as you can see, are not so responsive, but in this particular trial, had done relatively well. So I won't belabor the point. Quickly come to sarcomatoids. Sarcomatoids were included in all the pivotal clear cell RCC trials. And as you can see here, they did very well with immunotherapy. Checkmate 214 to highlight had an objective response rate of 60% with high CR rate of 20% complete responses. So if you have sarcomatoid RCCs, you must think of giving immunotherapy combination or immunotherapy plus TKI. So these are the guidelines. You can read this online. This is NCCN. Again, clinical trials are highly encouraged. We are working on the next version of the RCC guideline, should be out by end of this year or early next year. This was the previous version. We have a nice section on non-clear cell RCC as well. So in summary, RCCs consist of many histologies. Many trials are lumped together as a single entity and not so relevant because of bad results in the past. Now we have combination trials. Long story short, a lot of these may require a deeper interrogation of the tumor with next-gen sequencing to find what are the drivers, or you enroll them into clinical trials, and these two trials should read out hopefully next year, and we'll have new standards of care. Thank you very much.
Thank you for enlightening us. In view of the shortage of time, I think we'll not have any questions.
Okay. Thank you. Thank you.
Now, last talk on redefining outcomes of the adjuvant immunotherapy in RCC, Dr. Panda.
Good afternoon. I thank organizers. I can see some of